Before we watch Judith Beck demonstrate cognitive therapy, I have a few questions that I'd like to ask her about this approach. Welcome, Judy.
Thank you.
So, what is cognitive therapy?
Well, cognitive therapy is a psychotherapy that was developed by my father, Dr. Aaron Beck, in the 1960s. And it's a psychotherapy that aims to be as short-term as possible. It's very educative. We put a big premium on relapse prevention. And about half of what we do in cognitive therapy is to help people solve their problems that they're having today. And about the other half of what we do is teaching them certain skills, particularly cognitive and behavioral skills, that they need to get better.
So what is the basis of the foundation for this approach? You mentioned education. Is it like a learning theory?
Well, it is based on an information processing theory. So the theory behind cognitive therapy is that the way that people perceive their experience is more closely connected to their reaction, their emotional, behavioral, and physiological reaction than the situation itself. So one important part of cognitive therapy is identifying the thoughts that people have that then lead to a distressing or a dysfunctional reaction, and helping them to evaluate their thinking and change it so that it more closely resembles reality.
So the focus really is on thoughts and thinking. Is that how it's unique?
It's unique in that the theory underlying cognitive therapy really does put this premium on helping people change their thinking. The whole reason, though, that we want to help people change their thinking is so that they can have a lasting impact on their emotional state, on their mood, on their behavior, so they can act more adaptively and reach their goals. And particularly important with anxiety patients is that it'll have a lasting effect on their physiology.
So can you go through the steps and stages of your approach? And I believe you start with wanting to find a diagnosis?
Right. First, we do a very thorough evaluation, because the cognitive therapy treatment for one axis 2 disorder, such as depression, may be quite different from the treatment of another axis. Did I say axis 2?
You said axis 2. I think
right.
You meant 1.
I did. I meant axis 1. Sorry. The treatment for an axis 1 disorder, such as depression, has some similarities, but it is also quite different in other ways from another axis 1 disorder, such as obsessive compulsive disorder or eating disorders or substance abuse. At the beginning of treatment, we are generally socializing people to the cognitive model. So we're having them start to view their experience and their emotions through this lens of how their perceptions are influencing how they feel. We tend at the beginning of treatment to focus on the current problems people are having today, and kind of in a fairly methodical way helping them solve their problems. And oftentimes what gets in the way of solving problems are certain dysfunctional or inaccurate thinking. Toward the middle of therapy, we tend to put more of an emphasis on people's underlying beliefs, their basic understandings about themselves, their worlds, and other people. And then toward the end of treatment, we are really working toward termination, consolidating the skills patients have learned, and doing relapse prevention, so that when similar problems might come up in the future, patients know exactly what they need to do to solve them.
Now, you've mentioned relapse prevention twice. Can you talk a little bit more about that, what that means in your model?
Sure. We are not only trying to help people get well, but also stay well. And so we're actually teaching them to become their own therapists. When we use certain techniques with patients, such as identifying and modifying their thinking, we're not only doing that with patients, we're teaching them how to do it themselves.
That's where the learning and education comes in.
That's right. And we tell patients it's not enough to just come and talk for 45 or 50 minutes a week, but they're going to learn things in every session that they're then going to practice at home. And that's how we find that people get better, by making small changes in their thinking and in their behavior every day.
So that would be a big strategy and technique. Are there other ones?
Oh, there's lots. In fact, in cognitive therapy, we borrow techniques from every modality. So we obviously use a lot of cognitive and behavioral techniques, a lot of problem-solving techniques. We use biological techniques because many of our patients are on medication to begin with, or want to start on medication. Although we try to work without medication if it's indicated and if patients want to do that. We also use environmental techniques. Sometimes coming to see us once a week is only a drop in the bucket, for example, if the patient is going home and being abused every day, or if the patient is in such a deleterious work environment that it just is dragging them down every single day. We also might use Gestalt kinds of techniques or experiential kinds of techniques, especially when patients say, you know, I get what you're saying intellectually, but in my gut, I just don't believe it. Then we know we have to use more imagery techniques, psychodrama, things like that. We also, if I can mention one
Sure,
more, well,
yeah,
we use a lot of supportive techniques, a lot of good counseling skills, and we also use what look like psychodynamic type techniques, especially in developing the therapeutic relationship with Axis II patients, because we often find that they bring certain beliefs about themselves and other people to the treatment session and sometimes have negative thoughts about us therapists. And so we use the same kinds of techniques of identifying the automatic thoughts they have about the therapist or about the process of therapy, and then help them evaluate and respond to those ideas.
So the cognitive therapy, that's the lens that you look through, and then the way that you bring about change incorporates a wide variety of techniques and strategies.
Right. So it's important to understand that the therapy is not defined by certain techniques, it's defined by our understanding of patients. Not only that their thinking in certain situations leads to their emotional reaction, but we also want to take a look at what those underlying beliefs are. So patients oftentimes will have some very negative ideas about themselves, their worlds, and other people. And not with all patients, but especially with Axis II patients, it's very important to find out what happened to them historically, what happened to them as children that then led to the development of these very negative beliefs. And then we also want to find out, well, how have they coped with these negative beliefs all of their lives? What kind of behavioral strategies, coping strategies have they developed? What are some of their rules for living that may or may not have been helpful to them as children, but certainly are not universally helpful to them as adults?
So this is really a broad approach that deals with people in whatever way that they need to be dealt with, it sounds like.
That's
right.
right.
You really tailor this approach?
We do. We have to tailor it to the individual. So we take into consideration the patient's gender, age, developmental level. We get a very good grounding in their history. So we want to find out all about their psychiatric history, their medical history, educational, social, family, and so forth.
Now, there's a strong research base for your approach as well.
That's right. There are probably between 400 and 500 outcome trials that show that cognitive therapy is effective for a whole range of disorders.
What are some of them?
Well, all of the major psychiatric disorders. Now, when we have someone with severe mental illness, such as bipolar disorder or schizophrenia, we often insist that the patients be on medication as well. Although the more skilled you are as a therapist, the less likely you might be to absolutely need medication with patients. But with the severely mentally ill, of course, it's indicated. It's also very useful, and outcome trials have supported this, in the treatment of medical disorders with psychological components. So things like insomnia, overweight and obesity, fibromyalgia, chronic pain, migraine headaches, and a whole host of problems. And then for a lot of the psychological difficulties too, marital problems, couples problems, family problems, work problems.
So it seems it really works across the board.
That's what the research has shown us.
Yeah. Now, in a moment, you're going to be working with an actual client. What are you going to be looking for in this client? I mean, what's going to be important for you?
Well, the first thing I'm going to need to do is to find out what the patient's symptoms are. And so I will have had him or her fill out a Beck Depression inventory and an anxiety inventory, and we'll also get a subjective description from the patient of how he or she is feeling, especially compared to the past. So I will want to do that. The second thing that I'm going to want to do is to find out what's really important to the patient to discuss. So I will ask, what problem or problems do you want my help in solving today? And by having a very specific agenda, then we make sure to be able to cover what it is that's most important to the patient, which, by the way, may or may not be the first item that the patient comes up with. Sometimes when patients set the agenda, they'll say, oh, I want to talk about the problem at work because they've just come from work and they're very distressed by that. But instead of immediately launching into discussing that problem, I'll also ask the patient, okay, so there's a problem with work. Is there anything else you want to make sure and talk about today? So as you can see, cognitive therapy is a very collaborative process. We make decisions together on topics such as what to spend time on in the session, how to approach the problems, what kinds of follow-up things the patient might do at home.
You may have answered this question, but I'd like to, just to make it stand out a little bit more. So are you going to pay more attention to the symptoms, their story, you know, the narrative they have, their thoughts, their feelings, their behavior?
Well, I'm going to need to pay attention to all of them. So as they're discussing a problem, let's say it's a work problem.
Right.
I'm going to be finding out many different things. So I'm going to find out what is the specific problem, when is it the worst, how long has it been going on, what have they already tried to do to solve this, and so forth. So I'll collect a lot of data about the problem.
So that's some history about the problem.
That's right.
Okay.
And then I'll find out when was the problem the worst this week, or when did the patient feel the worst about the problem this week. What was the emotions that the patient experienced. When he or she experienced those emotions, what was going through his mind or her mind? What were the patient's automatic thoughts?
Oh, okay, so that's when the thoughts come in.
Right. And then I'll want to find out, well, what did the patient do?
Yeah.
And if it's an anxiety patient, especially where there's some physiological reaction. So I'll want to flesh out the cognitive model in that way. And then I'll think to myself, and I'll also collaboratively agree with the patient, where are we going to start working? Are we going to work at the problem situation level and do problem solving? Are we going to work at the automatic thought level and help the patient respond to distressing or distorted thinking? Is the patient so upset that we're going to work at the emotional regulation level and bring the patient's emotion down a little bit, maybe through distraction or speaking more conversationally, and before we get back to the problem? Are we going to work at the behavioral level? Maybe the patient would benefit from some skills training. Or maybe the patient is so anxious that we will do some relaxation training to get his physiology calmed down. So I'm going to be collecting a lot of data about the problem and then collaboratively with the patient decide where to start working. We might work at one level, we might work at all of those levels. If it's more toward the middle of treatment, we might be working more at the underlying beliefs that then gave rise to the automatic thoughts.
Okay, so you've got a lot of things that you want to make sure that you do, depending upon the stage. What do you not want to do? What do you want to be sure to avoid?
Well, I certainly want to avoid anything that would damage the therapeutic alliance. So the therapeutic alliance, I don't care what kind of psychotherapy it is probably the most important element in psychotherapy. Now, it's important and it's necessary to have a good relationship, but it's not sufficient.
Not sufficient, right.
So I want to make sure and be collaborative with the patient. I want to get feedback from the patient. I want to make sure that the patient and I are on the same page. I want to make sure that the patient is understanding what I'm trying to tell him or her. And I especially want to prepare the patient to have a better week. So I not only wanted to help him feel better in the session, but I want to think to myself and out loud with the patient. So what we've just gone over, how can that help you have a better week? What would be important for you to remember? What would be important for you to do? So I want to avoid discussion that ends in the therapy session with no follow-through.
So what will make for a good client for this approach? I mean, what does it work best for?
Well, maybe another way to say that are who are easy clients. And the clients who are easy in cognitive therapy are the clients who are easy for any kind of psychotherapy. So the ones who have a lot of internal and external resources whose lives aren't in too much chaos. The ones who are more easily socialized to treatment. So those are the easier patients. We really need to look at research to see which patients might not be as appropriate for cognitive therapy. And research really hasn't shown us that yet. It seems that most of the research shows that cognitive therapy is about as effective as other treatments for the whole variety of disorders.
And a final question is, what will make for a good session? I mean, what will be effective?
Okay, so my definition of a good session is the patient feels better by the end of the session, and the patient has a really good plan to have a better week. So the patient has learned things in session that he's not only probably going to use this week, but hopefully when problems arise a year from now or 5 years from now or 10 years from now, he'll be able to go back to his therapy notes, because we make sure that patients or therapists write down for the patients whatever they want the patient to remember. He'll be able to go back to the therapy notes and make use of the things he's already learned and put them into place with either the same problems or new problems.
Well, we're going to go now and watch you work, and I'm pretty confident that the same excitement that you showed in this interview will carry forth with the clients. Let's watch.
Thanks.